So, welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have a super exciting guest today, is Dr. Danielle Cerbon. She is a physician and assistant professor here at UF. She's a radiation oncologist and she grew up in Mexico City when she earned her Bachelor's of Medicine and Surgery from University of Anáhuac in Mexico Norte, graduating top of her class. Her performance allowed her to do part of her clinical curriculum at the University of Miami, where she met her mentors who, upon graduating, hired her as a research assistant for 1 year while she successfully passed all the required exams in order to train here for her residency in the USA. She began her medical training in 2020 with an intern year in general surgery at Jackson Memorial Hospital, University of Miami, and following by a resident in radiation oncology at the same institution. And she joined us, that was last October, here at UF in Gainesville. And we are super excited to have her here. And thank you again for wanting to be part of the show.
Thank you. No, thank you so much for inviting me.
Absolutely. So, Dr. Cerbon, tell me what led you to specialize in radiation oncology, particularly in pelvic cancers.
Yes, so I guess um, following kind of that introduction, that lovely introduction that you just gave for me, when I was studying medical school, I was able to do part of my medical school, 6 months of it, of all my clinical rotations at the University of Miami. And so while I was there as a student, I met one of the kind of most impactful mentors that I've had. She, at the time, was a breast oncologist and the program director for the oncology fellowship in University of Miami and Jackson Memorial. Her name was Judith Hurley, and she has done a lot of incredible work in the field of breast cancer. So while working with her, I kind of fell in love with oncology as a field. Um, just in general, working with patients that have such a scary diagnosis like cancer. Initially, though, radiation oncology is something that is a very unknown, I feel like, field of medicine. Even as a student at the time, I hadn't had a lot of exposure to it. I didn't know much about it. So I initially started my career thinking I was going to be an oncologist. And once I graduated and was hired by Dr. Hurley and some other mentors, um, for doing some research in breast cancer. Once I was working, in these research projects is when I came across more in depth with radiation oncology, where I met other radiation oncologists and saw how much more involved they are than what I thought. I think there's a big misconception when people hear the word radiation, they think radiology.
Mhm.
Um, and even when I was in medical school, I thought that. I used to think they were basically the same doctor, just maybe like a subspecialized version of radiology,
Okay.
but it's actually a completely different field. And so I learned how they're basically also oncologists. They're not radiologists.
Mhm.
They're oncologists, but instead of treating with chemotherapy or surgery, they're treating with radiation therapy. And that in itself is like a whole separate science. And I feel like I have a very curious mind. I always love continuously learning. And so I fell in love with, once I started learning about radiation, I fell in love with it and decided to, instead of doing medical oncology, moving into radiation oncology.
And I'm so glad you did that because that's why we have you here.
Thank you.
So, why pelvic cancers?
So that part is also a little bit related to my decision of doing radiation oncology and my trajectory into radiation oncology, is that when I came to America after graduating, my research was all in minority populations, looking at hereditary breast and ovarian cancer and the burden of these mutations in the Caribbean population. In the Caribbean population and in general, the African diaspora, because one thing that a lot of people don't realize is that Black people are not just one group. There's, subgroups within Black patients that might be African Caribbean or African American. And depending where you come from, the genetics associated to your cancer burden, your risk, and everything changes. So when I was working with all these female breast cancer patients, I realized how we live in a man's world. And so I realized there doesn't seem to be a lot of support when it comes to um, things that are very close to home when it comes to women, like sexual health. And in general, it's just a scary treatment, even with the breast cancer patients that I was seeing at the time, having your chest completely on display and they have to like touch it and just do a physical exam. It's just all very scary. So when I went into radiation oncology, I decided that, at least personally, I feel like if breast is scary, having, the pelvis exposed and being treated is even more vulnerable.
Yeah,
So
absolutely.
I wanted to be a woman treating other women so that it's already a very scary experience. So I kind of want to make an impact in
Gotcha.
that way as well.
So for listeners who may don't know, what cancer are considering pelvic cancers?
hmm so pelvic cancers are anything that is kind of the way I like to phrase it is sort of from the waist down.
Okay.
But when we talk about cancer, there is an introduction that I really like to give all my patients. And I think not just cancer patients, but I think most people um, would benefit from knowing this, is that there's this misconception where people think that cancer is one disease. And so, when I got into oncology, I would have friends back home um, make jokes like, "Oh, when are you gonna cure cancer? When are you gonna find the cure for cancer?" And that's kind of like saying, "When are you gonna find the cure for infection?" Meaning, cancer is not one disease. So if I were to tell you, "Oh, well, I'm going to the doctor because I have infection," you'd be like, "Well, what do you mean? Like where?"
Mhm.
And if I told you, "Well, actually, I have an infection of in my neck," you would say, "Okay, where in your neck? Like in your throat, in your tonsils, or in the skin?" Like. And even if I told you, "Well, it's not in the skin of my neck, it's actually in my throat," even then you'd be like, "Where in your throat?" And once I told you, "Okay, you know what? It's an infection in my tonsil,"
Okay.
you would say, "Okay, is it a virus or is it a bacteria?" Because,
Mhm.
if it's a bacteria, you need an antibiotic. If it's a virus, you might need, an antiviral or some other medication. And if I were to tell you, "Well, it's actually a virus," even then, it still doesn't narrow it down to the sense where, yeah, you could have a virus like just a common cold,
Mhm.
or you could have COVID, where it's, something that can be very scary, very deadly. So, and each one is treated differently. So, cancer is similar in that regard, where if someone were to tell me, "Well, you know what, my family member got diagnosed with cancer," I feel like most people, because they have this idea that cancer is one disease and they have this like doom and gloom of cancer is just a very scary word.
Mhm.
Um, when you say that, people right away go, "Oh my God, I'm so sorry to hear that."
Yep.
And that doesn't necessarily have to be the response
Yeah.
because nowadays there's many cancers that are curable. There's many cancers that are considered very, as we say, indolent, which is just like a fancy word for not very aggressive.
Mhm.
Same as infections. I like to say that the way that we react about cancer these days is kind of like how the medieval times people would react to an infection because
Yeah.
penicillin didn't exist. So you had an infection and that was it. You were going to die. But nowadays, we shouldn't really think that. We should think, okay, where is the cancer? So when people tell me my family member was diagnosed with a cancer, instead of jumping to conclusions, I ask, okay, what kind, where? And so going from there, that kind of helps understand, okay, what are pelvic cancers? Well, they're types of cancers that happen in organs in the area of the pelvis, which is basically kind of starting from the belly, like lower from the belly button down. Usually it includes the genitals, but it can also include reproductive organs. So, for example, the uterus, the cervix, which is kind of like the neck of the uterus, the vagina, the vulva, but also not just reproductive organs. What else is in that area? The bladder, the rectum, the anal canal. So all of this is pelvic cancers.
And what makes radiation therapy such an important tool in treating them?
Well, that actually goes into kind of like the next step of what I like to discuss when I'm explaining things with my patients is that, okay, now we know that you don't have, one single thing, you don't just have cancer. You have cancer of this area, and this is the type that you have. But what does that mean? They tell you, oh, for example, in pelvis, one cancer that's kind of common is, for example, endometrial cancer. And patients get told, well, you have endometrial carcinoma. What does that even mean, right? And so what that means is just that our bodies are made up of, everything is made up of like the building blocks. And so in our body, the building blocks are cells. So each part of our body, if you go smaller, 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 it's made up of cells. And inside the cells, I guess like all of the information of how our body works is the DNA. So the DNA is inside of each cell in your body, and it has all the information. It's almost like the hard drive of how your body will work. And so even if it, for example, you have a skin cell, it's obviously going to be different than an eye cell. But the DNA in both has all of the information of both. It's just that it's giving the directions of what to do. So the DNA in the skin cell, it's telling it, it has the genes for the skin cells. It tells it, be this color, do this things, these functions, and the same for the eye. And then in the eye, it has the skin information, but it has it turned off. And it has the eye information turned on. So when we get a cancer, what happens is that the DNA in these cells basically changes. It gets a mutation, which is just like a damage in that DNA. And once it's damaged and it's not repaired by our normal repair mechanisms, then that continues to be there and it becomes a cancer. It's a DNA that's telling the cells, keep growing, keep invading. It's no longer giving it the right information.
Gotcha.
So when that happens in an organ in the pelvis, the way that we decide what type of cancer it is the type of cell that originally had that problem, that mutation in the DNA. And so there's many ways that we can treat cancer. And the most archaic, like the most known is surgery. And I have so many patients that come to me and they're like, well, why can't they just cut it out? Because it seems intuitive, something growing there, just cut it out. And yes, many times we can. So that's where the surgical oncologists come in. But sometimes, even if you cut it out, at the end of the day, the problem is those DNA in the cells that has, that mutation. And you can't see single cells with your own eyes. So when you're cutting things out, you're cutting what you can see, but there might be cells left behind. So, okay, what do we do with those cells that are left behind that might have that defective DNA that's causing the cancer? Well, there's a couple of things we can do. One is we could give chemotherapy, which is what most people are familiar with. And that's because chemotherapy can kill those cells directly. That's why they say chemotherapy is like a poison, because at the end of the day, it does hurt those cells. And there's chemotherapies that hurt the cell directly or that hurt the DNA of the cell. There's just many different kinds. Now, the chemotherapy, the way that it works is that it's a medicine. And a medicine goes into, if you take it as a pill, goes into your stomach, and from your stomach, it gets absorbed into the blood, and then it goes to the whole body. If they put it through the vein, then it goes directly into the blood and to the whole body. But chemotherapy is what we call systemic therapy, meaning it goes in the blood and it goes to the whole system. Sometimes we might say, okay, well, we don't want to treat the whole system. We just know that they did the surgery and there was a little bit of cells left behind. And what if we could just kill them with something else? So a local treatment would be radiation. The way that radiation works is that we use a kind of radiation that kills the DNA of cells. And so we focus it only on the area where we want to treat that cancer. And the way that we decide that is there's many different clinical trials that we do where we do different types of treatments. And once we see which one works best from these three options that I just talked about, then that's how we know, okay, well, in this group of patients, we used surgery and radiation and they did better than surgery and chemotherapy or
Okay.
things like that. So that's in the end how we come up with these treatments.
Got you. So many patients feel fear when they hear radiation. So what would you say to someone who is really anxious about starting treatment?
So one thing, I like this question a lot because one thing that I always tell my patients is the word radiation is just in itself a very scary word
Mhm.
because if you ask anyone in the street, what do you think when you say the word radiation? They would think bombs,
Yeah.
um,
Mhm.
outer space, maybe aliens, cancer, obviously. Um,
A lot of damage with it.
yeah, it just makes you think of like really bad things.
Mhm.
But really, radiation is something that there's many different kinds of radiation, and it's everywhere. So, for example, the light that we can see from a light bulb is a type of radiation.
Mhm.
And so, different types of radiation have different effects in our body, but also different doses of each kind has a different effect in our body. So, for example, with the light bulb. So, light from a light bulb is a type of radiation. The effect is that we can see light. If
Mhm.
you were to decrease the dose, then the effect is that you can't see anything. And
Mhm.
then if you increase it a lot, it could even blind you,
Right.
you know? So there's like just different effects. When it comes to radiation therapy, what we're looking for is for a type of radiation that the effect that we want is called ionizing, which is just a fancy word for radiation that we know can hurt the DNA of cells.
Okay.
And the next questions I usually get from patients, like right away, is, well, how does the radiation know
Where to go?
what DNA to hurt, you
Yeah.
know?
Yep.
And so the answer is it doesn't. So the way that we're able to kind of guide it a little bit is that's why it's a local treatment. And so we only give it to the area where either the cancer is or where they did the surgery and it used to be.
Mhm.
So we give it to only that area and there's normal cells around it. The difference with cancer cells and normal cells is that cancer cells, like we said, have damaged DNA. They've mutated. They're no longer the same as the original. And so our normal cells naturally have ways to repair DNA damage because as humans, we're meant to have repair mechanisms for that because we're constantly being exposed to different types of things that could damage your DNA. But cancer cells don't have those repair mechanisms normally because their whole point is to just reproduce as fast as they can. They're not going to take the time to really like fix errors.
Mhm.
So when we give radiation that can damage your DNA, then like patients ask, how does it discriminate? It doesn't. It damages everything in its path. But your normal cells can repair themselves from that. The cancer cells won't, and they'll end up dying. So that's kind of like the idea behind how we treat with radiation therapy. Now, another question that I get, because it's like, okay, well, it's still scary because it's still radiation that can hurt my DNA. So is it gonna burn? A lot of patients ask that.
Mhm.
Um, like when I'm getting the treatment, is it gonna hurt?
Mhm.
And really, that's not the case because the type of radiation that we choose that is the one that can hurt the DNA of cells. The most common one and what most people will be familiar with is X-rays.
Mhm.
And so X-rays more commonly are used for imaging or the field that we all get confused about, which is radiology.
Yep.
So radiology uses X-rays at low doses, very, very low doses, where they can get an image. That's the whole point. Their point is not to damage the DNA.
Mm-hmm.
So the way that I like to explain it a little bit better is, imagine I grabbed a piece of paper and at the edge, I did a motion in my skin where I run it really quickly through my skin.
Mm-hmm.
That could give me a paper cut.
Mm-hmm.
But it also can not give me a paper cut. It's, it might happen, it might not. Even if I did get a paper cut from that, it's so small that I might not even notice when it happened. And it will heal so quickly, it won't even leave a scar. It'll be like it never even happened.
Mm-hmm.
Now, if I were to do that same motion, but with a really sharp blade, that will cut my skin.
Yeah.
It's not even a matter of maybe it will, maybe it won't. It will cut it. But also, again, my skin can heal from that. It's just that when it heals, there's going to be a scar left behind and it's going to be more symptomatic. It's still going to get more symptoms than a paper cut. It's going to take longer to heal, everything. So when it comes to x-rays, I like to explain radiology as the paper. So when you get a CT scan or just a normal chest x-ray or a mammogram, you're getting x-rays that might damage your DNA, but the dose is so low that it most likely won't. And even if it does, your normal cells are very likely to just heal that damage or repair it. When we're giving x-rays in radiation oncology, the doses that we're giving are much higher. And so to the point where we know it will cause DNA damage because that's what we want.
Mm-hmm.
It's just that your normal tissues around it will heal from that and your tumor probably won't. But
Okay.
at the end of the day, it's x-rays. When you get an x-ray, regardless of the dose, you don't really feel anything. So
Okay.
when we give the treatment, you don't feel anything. It's more afterward that you might have some of the side effects that come from those cells having been hurt and trying to repair themselves.
Got you. So what are the most common short-term side effects that the patient should expect?
So in terms of short-term side effects come from what I was just explaining where you get that DNA, like initial DNA damage in the cells. And so, for example, in the pelvis, if I were to treat, for example, the uterus,
Mm-hmm.
if I'm treating the uterus, everything that's around it will receive some dose of radiation. It might not be the very, very high dose that I'm giving the uterus, but still, when I'm using x-rays and it's coming from outside in, some low dose is still going to touch all of the areas around it.
Mm-hmm.
And so what is around, for example, the uterus? Well, the bladder is right in front, the rectum is right behind, the vaginal canal is underneath, and then the bladder is connected to the outside through the urethra. That's where, the urine comes out. And so all of these areas can, when their DNA get damaged and they're trying to repair it, it basically is like irritating them.
Mm-hmm.
So side effects could be, burning when you urinate, for example, symptoms similar to a UTI where you feel like you need to go to the bathroom more frequently, or maybe it burns a little bit. Or if the rectum gets irritated, the kind of like anorectal canal, similar symptoms to when you, for example, have diarrhea and you have that feeling that you need to go and push, but then nothing comes out, and it's a little bit of burning and diarrhea. All of that can happen, but it doesn't happen straight away because first the DNA gets damaged and then it starts giving the symptoms. So usually when patients come for treatment, we give the treatment over several days. And so the first few days, they don't really feel anything. It's
Mm-hmm.
almost as if they were just getting a CT scan.
Mm-hmm.
And so after a week or two is when they start noticing these short-term side effects. And that's what happens in the pelvis. But for example, in the breast, I think most people are familiar with radiation for breast cancer because it's one of the most common cancers in women. And they see, these like really, sometimes they see this really bad burn in the skin.
Yeah. Yeah.
Not always, but when we see that, well, that's because we're treating the breast, and the breast is right next to the skin. Like there's nothing in between the breast
And the skin.
tissue
Yeah.
and the skin.
Yep.
So when you're giving that high dose is going to the skin as well. And so you're getting this very, redness and it hurts. When we're treating the pelvis, it's less likely to get this burning
Okay.
because we're treating deeper.
Got you.
So the side effects are more whatever is near the area where the tumor is or where you're trying to treat is what will get side effects. So when people ask me, am I going to lose my hair? Unless I'm treating your head, no. I always say you can blame the other doctors if you get like, for example, if you get a headache, you could blame your husband for that, but,
Uh-huh.
or the other doctors, but
Yeah.
not me because I'm only treating the pelvis.
Okay, got you. So you kind of touch a little bit about how pelvic radiation can affect the bladder, but as well can affect the bowel and sexual health. How how you think we should minimize those side effects?
So, one thing that I like to do is we, as a team in radiation oncology, we give patients a lot of teaching materials to
Mhm.
help with, for example, diet. So if you know that you're going to have some burning with your bowel movements, then it might be ideal not to eat spicy foods. Or if you know that it's going to cause a little bit of diarrhea, then eating things that are very high in fiber that will cause you to have bowel movements is probably not the best idea when you're already having a lot of bowel movements. So we give patients diet, kind of like a diet recommendations um, to minimize those side effects. And same thing for the urinary side effects. One thing that's important to keep in mind is that not all patients have the same degree of side effects, and not everyone gets all of the side effects.
Mhm.
And so some patients might really not have much of a problem with, burning or urinary side effects. Some
Mhm.
might. So um, we try to minimize with certain diet interventions, but as things come up, we try and help. Now, when it comes to sexual health, especially for women,
Mhm.
we're treating the area right where the vaginal canal is. And like I said, these cells, will get hurt and they will start a repair process. Whenever that happens, always in the body, scar tissue will be created
Mhm.
because it's like the body goes into this,
Mhm.
oh, there's been injury, we need to heal it and create a scar. The
Mhm.
problem is we didn't do like one cut. We're like really treating the whole vaginal canal. And so what does that look like when you have scar tissue all over? Well, scar tissue is not very flexible. And so um, if you think about the fact that it's not very flexible, then the vaginal canal can lose a lot of its elasticity. And
Mhm.
so one of the big long-term side effects that we worry about with women is what we call vaginal stenosis. And
Mhm.
stenosis is just a fancy word for narrowing.
Mhm.
So getting a very narrow vaginal canal that then with intercourse can be painful, but not just intercourse, just in general, these women are going to have to get pelvic exams regularly to make sure that the cancer is not coming back. And so we want to make sure that it doesn't close up where it's really painful every time they get a pelvic exam. And so there's many ways that we can try and help. One of the things that I sometimes like to do is give a vaginal gel to try and keep the area lubricated. But the most common thing that is standard of care everywhere, and every radiation oncologist should do, is after you get pelvic radiation, is using what we call vaginal dilators.
Mhm.
Basically, they're kind of like a big, not very big, but like a relatively big plastic tampon is
Mhm.
kind of like the way that I describe it. And you just insert it, and it's important to keep using them regularly. For example, inserting them for 5 minutes every day after you have radiation, because that way we can keep the area open and make sure that it doesn't end up closing up to the point where the walls of the vaginal canal fuse together and then there's no entrance.
Do you recommend that to be happening during radiation, after radiation, when after radiation? What are
So
your
we don't do it during because the scarring process is kind of like I said, a long-term side effect.
okay.
Um, it's kind of the reaction to that initial injury where initially during the treatment, some patients do have some burning, some patients don't. But even if you don't, that injury is happening. Then once we finish with the radiation, that injury stopped, and now the body's like healing itself.
Mhm.
That's when that scarring tissue process starts. And that's when we really want to get ahead of it and make sure it doesn't become a problem. So usually I let the patient heal, kind of rest after all of the treatment for 4 weeks.
Okay.
And then I recommend starting using those vaginal dilators. But they could start right after. It's just that sometimes, it's
We
a little
risk.
bit too early. If they started, they might feel a little bit of burning. So we wait for that initial injury to be finished. And usually scar tissue starts forming right around 4 weeks. So that's when we start with the dilators.
And then how important is pelvic floor or physical therapy in this area as well?
So important. And I'm glad you brought it up. That's actually one of the things that I forgot to mention when, in terms of what do we do to help minimize these risks and help prevent. Um, pelvic floor therapy is very helpful for many reasons, but one of them is as women, especially if you've had children before, the pelvic floor is just, it gets weakened with time. And then if you've had children, it's already been stretched out and back, etc. So a lot of women are like, well, actually, after I had kids, when I sneeze, I like have to cross my legs because it's just and so if you're already going to have radiation and it's already going to irritate the area, it's going to make you have more frequency and it might hurt, that the strength of that pelvic floor with all of that scarring happening might decrease. So if
Mhm.
you already have a little bit of incontinence, we don't want to make it worse by, weakening the muscles that help keep that continence.
Mhm.
Um, and so a lot of women, when I say, oh, well, we should do pelvic floor physical therapy, they're like, well, I already know I have to do Kegels. And it's like, well, yes. But the physical therapists kind of guide you through not just the classic Kegels, but, um, what can you do to help make maybe your bowel movements a little bit less uncomfortable? What's the best way of using that dilator so that,
Mhm.
it really gives you the best benefit? And also help you with, urinary tactics
Mhm.
and lifestyle changes so that it really doesn't impact your lifestyle as much.
That is true. And most of people think Kegels, right? Every time you talk about urinary incontinence, and doesn't matter if it's frequency or urgency, the first thing that comes to their mind is Kegels. And do you know that how many people do Kegels wrong to beginning with?
Exactly.
Then some of them don't even need that. So sometimes I explain to them when you go to a physical therapist who specializes in pelvic health, they have the ability to find like muscles on the pelvic floor, like any other muscle in the body. So you either can have weakness, which for that Kegels can be a very good idea, but sometimes you can have a
Hmm.
lot of tightness and you don't want to create more tightness by doing
Exactly.
so they
Exactly.
can use so many different things. They can use biofeedback and other things to try to really work on that area. And again, the pelvic floor has such a correlation with your core muscles and your lower extremities that all that needs to be working together to be successful. So it's really
Yes.
important. So, and again, we are so blessed that you guys refer all your patients. And so we are able to work on education and start looking into all those things that are so important for patients
Yes.
later on. So right now we were kind of chatting a little bit yesterday, and we talked about how many women already have issues even before a cancer diagnosis. And
Exactly.
cancer diagnosis happening, and then we know more likely those issues are going to even become worse. So the sooner we
Correct.
can start to address those to mitigate some of the side effects, the better.
Exactly. I think physical therapy to me is it's not just, strengthening and um getting like tactics to address certain issues, but I feel like it's a matter of quality of life. I do think that um, seeing a physical therapist when you have any type of injury, and radiation therapy at the end of the day is injuring the pelvic floor, is very important to know exactly how to tailor, because everybody is different and their injury will be different. So it helps tailor how to go about this injury, identify any problems,
Mhm.
and then know exactly what to do.
Yeah, that's perfect. How do you collaborate, or actually, what happens between diagnosis and the first day of radiation treatment?
Oh, yes, it's a whole process. So, I always like to say that part of the reason why I went into radiation oncology is because I love working with a team. And I think it's one of the most teamwork um, dependent fields of oncology,
Mhm.
because there's so many moving parts. So, the way that we even start a radiation plan patients, when I explain all of that, you know what I said when it comes with the x-rays and how we, guide them to that one area and all of that. The patients always say, well, how do you know that you're actually giving the x-rays where they need to go?
Mhm.
Um, and so the way that that happens, another question I get, not just that, but they're like, okay, so when do I start? Like, do I start tomorrow? And I'm like, oh no.
A long, long time.
Because it takes a while to really,
Yeah.
it takes a village and it takes a while to really make a radiation plan so that it minimizes damage to normal tissues and maximizes control of the cancer. And so the way that it works is the patient comes in for their consults. I explain everything that we kind of have talked about. They sign their consent for treatments. And that day we get an appointment for what we call a simulation scan. It's a simulation or planning scan.
Mhm.
And so this, we call it a simulation scan. It's usually a CT scan or an MRI scan. The reason why it's called a simulation is that we simulate the position of the treatment, but instead of treating, we just take an image. And
Mhm.
so when we place them in the position of the treatment, we get to submillimetric precision of exactly how they are aligned. And then we make specific molds to kind of every time when they come back, they're in that exact position. So based off of that simulation scan, that is like the second appointment that they come to. Then I plan that radiation. And so I look at that scan and I see, okay, in that position, where is the tumor? Where are all the normal structures? And I literally draw them in.
Mhm.
Then I also create a prescription. And so in that prescription, I say, okay, I want this much dose to go to the area where the tumor is or where my target is. And this is the maximum that can go in the rectum, the bladder, everything else. And so then all of this, I then give to our physics doctors. And so it's a whole team involving engineers called dosimetrists and the physics doctors who then, based off of my um,
Prescription.
prescription and drawings, then create exactly how the machine will move to really deliver that. Once they have a plan, they share it with me and I see if it's meeting what I want. And that's where the personalized part comes in, where, it might be meeting the prescription, but if I know that, for example, this is a patient that already has a lot of bowel problems, then
Mhm.
I might tell them, you know what, we need to push a little harder in decreasing that dose in the bowel.
Okay.
And so they might go and perfect it more. Eventually, once I'm happy with it, I approve this plan and then we can start treating the patient. So from the moment they get that simulation scan to the moment they start treatment is usually about 8 business days, so around 2 weeks. So really from the day that their consult starts to the day they actually start treatment is usually about a 3 week turnaround.
Mhm.
And when they start the treatment, usually it's an everyday treatment that can last several weeks, usually Monday through Friday. And patients come in, get the treatment, and go home. It's not something that they have to stay admitted in the hospital.
Mhm.
And it's usually, especially the first week, it's very easy. The patients come in, they get lined up, and then get treatment. And because x-rays, you can't see them, touch them, feel them, taste them, smell them, nothing. They're just laying there and they're like, oh, that's it.
That's
From the
it. Like,
moment they get here to the moment they leave, it might be like, I don't know, 40 minutes maximum. So it's an easy treatment. It just starts getting a little harder as we progress through the treatment once they start getting some of these side effects. And to your question, how I collaborate with other doctors is I I'm in contact. A lot of times we have to give this treatment along with chemotherapy, for example, where once a week they're getting chemotherapy and we're treating with radiation every day. So
mhm.
I'm always the teamwork is not just with my team of engineers and physics experts, but also with the other doctors like the medical oncologist or the surgical oncologist, where we coordinate so that everything is timed perfectly so that we can kind of kill that or cure that cancer.
Yeah. And as well, I'm part of the collaboration. Like I mentioned before, we are so blessed that we are part of your team as well. So many times we have patients who come here. And like I say, we are blessed that most of your radiation patients come here, not necessarily pelvic, but any radiation. And many of them in the beginning, like you say, they're like, I have no idea what I'm here for therapy. I'm doing fine. I just start and I'm doing totally fine. So that give us a time to do like an evaluation where we can establish a baseline and see, okay, what is fine means or where you're thinking is fine is not maybe where you think you are at. And then we can as well help a lot with just reinforce all the education about these side effects, right? Because sometimes it's a lot of information that they receive from your nurse and they're just overwhelmed. And then it's like, well, they never told me I was going to have this. And it's like, I'm sure they did. It's just a lot of information that your brain will retain. So we just try to reinforce, yeah, remember, this is all some of the side effects that we want to try to help to mitigate by doing ABC, and then we try to really help them. And not necessarily we have to see them like weekly, but more likely we will just try to follow them. If they're doing really well, then we try to follow them halfway through radiation. Sometimes we're thinking, I remember having a guy with young athlete guy doing CrossFit feeding with um, throat cancer and it's like you'll do great, like you're really fit, you have no issues. I will see you towards the end of radiation, but just give me a call if you need anything before. And the poor guy not only have complications because he developed COVID. So that was terrible.
Oh
And
no.
then he was so dehydrated. So he ended up in the hospital with IB. I mean, he lost so much muscle mass because he couldn't work out. I mean, it was like, oh my God. So it just was kind of like an eye-opening for us to say, well, let's just not judge based on what they now are doing. Let's just keep an eye on them closer and let's for sure see them like halfway no matter what, because
Exactly.
you don't
Because you
know
don't know how things will change. Exactly.
exactly. So we really try to work on that to kind of really keep them going with some of those side effects.
Hmm.
What advancements in radiation technology are you giving the most hope right now?
Oh, well, I think for me, I get a lot of patients asking me, there's a lot of new radiation types that are very fancy. So I get a lot of patients come in and ask me about proton therapy. I think that's kind of like the hype of radiation these days. Um, but personally, my biggest hope and excitement is not in that field. Um, for me, the new technology that I really like is called MRI guided radiation. And so, what that is normally when we give radiation therapy with external beams, we use in order to align the patient each day so that they're in the exact same position as that simulation scan. We use a very low dose CT. It's called a cone beam CT. It's almost like the CTs they do in the dentist. And
Okay.
so we do that every day. Right before the treatment, we see how everything is looking, make sure that nothing changed too much. For example, the bladder is not very full, completely different from what we planned on, anything like that. And then once we see, okay, it's looking similar to the first day, then we treat.
Mhm.
Problem is, as we're treating, you don't have the CT live.
Okay.
So If the patient moves as we're treating, and we immobilize them, so it's, very little that they would move, but um, then we don't really see that. Or more importantly for me, if the bowel moves, you can't immobilize the bowel, right? So patient can be completely immobile. It can be in the exact same position, but the bowel, I mean, you can't control if the bowel's
Yeah.
moving.
Yeah.
So with the treatments that I give, just the standard ones, it's not necessarily super important to have a live feed of what's happening inside of the patient.
Mhm.
But sometimes we need to give a much higher dose, and we're limited by the fact that the bowel is in the way, and what are we going to do about that? And in those cases, nowadays we have this MRI guided technology where as we're giving the treatment, we have a live MRI and we can see exactly everything that's moving. And if while the machine is on, the bowel gets in the way, the machine will turn off.
Oh, nice.
So that's to me is just great, especially for areas in the pelvis where there's, the tumor is like literally right next to the bowel. And I'm like, how am I supposed to treat the tumor to a really high dose if the bowel is just like, they're fused together? So in certain cases, this technology has given me so much more flexibility to help patients where otherwise, we might not have been able to treat them as well. The machine that we have is called a Unity machine because a lot of patients, instead of hearing MRI guided, they might hear Unity.
Okay.
Um, and so that's kind of like the type of radiation that I really like to give. That one and the internal radiation is something that a lot of our patients get. It's called brachytherapy. And it's instead of using x-rays coming from outside, we use a radioactive seed
Mhm.
and insert it directly in the tumor. I think that if we're able to get a little bit more technology on that side of things, I think that that will also be extremely helpful. I think it's still a growing field. So
So we
those two
have,
are,
so, so we have that option already here.
we do. We have both options available here at UF. There are certain internal radiations in terms of brachytherapy. There's certain types that we are not able to do here.
Okay. And
But
I have heard that for prostate, but not so much for pelvic health.
yeah, I don't think we're doing it for prostate here. They're doing it at Jacksonville. I'm doing it for the pelvic patients, but there's certain cases where the tumor is the size is just not appropriate for the type of
Gotcha.
the applicators that we have, the technology. So in those cases, sometimes I have to refer the patients to other centers.
Okay. Excellent. And where can people find you?
Oh, find me. Um, well, I will say I used to be very active on Twitter, social media. As I've got busier, I've not been as active. I'm trying to kind of get back in there, but definitely on my Twitter and just on, here at UF Radiation Oncology in Gainesville um, is kind of like the best ways to find me.
Perfect. And I'll put that on the show notes. So, Dr. Cerbon, this has been amazing. Thank you for that great explanation. I'm sure the audience really will enjoy and learn a lot of the education. I've been using this podcast platform as a part of the education for our patients. I think that is important. Like, sometimes when they listen on their own time and listen a conversation like this, like, okay, what is radiation and explain the way that you explain that really give them a peace of mind to
Mm.
understand, okay, what is all this instead of everything just kind of like dumped to them, right? Like here you having this
Yeah.
simulation and this how many weeks it's gonna be and they're just recovering from surgery and just try to figure out what they're gonna do. So this has been a really great way to continue helping them through their journeys with this treatment. So I really appreciate for you to be part of it.
Well, I'm really grateful that we have amazing people like you here at UF and that you invited me because even I'm going to use this one. I'm going to start telling my patients to listen to it before they come so that they get an idea of how things work. So I appreciate you doing this. I think it's an amazing help for all of the patients out there.
Thank you so much, and you have a great evening.
You too. It was a pleasure.
Thank you. Bye.